Cardiac therapy is the fundamental treatment to prevent thrombotic complications y deaths in several cardiovascular disorders such as ischemia, DC arterial fibrillation, as a stroke. Normally, you look through our arteries and veins, smearing a efficient book. If after clot or thrombus block the soma flow on the wall, the result can the thrombosis can be serious and even cause death. With no an area of drugs that can be used to prevent it. Thrombosis and tertiary more on the way. This was not always the case. Applications de nursing. Continuous electrocardiography monitor blood pressure, monitor blood gas, zone de pain, vectors in the 12 or several pains, and monitor stable with episodes of recurrent ischemia. Patient or family information, secure branch line, oxygen supply during the first dose, 2-3 hours, or will pain persist, so jacks in the first dose 12 for big episodic death. Routine use de antidiuretic pulse oxygenator.
Reduce thromboembolic events and bleeding risk is dual therapy with the oral direct thrombin inhibitor dabigatran, 110 or 150 milligrams twice daily, and a P2Y12 inhibitor. The primary endpoint was time to first major or clinically relevant non-major bleeding within 14 months. The rate of major or clinically relevant non-major bleeding was 15.4% in patients receiving 110 milligram dabigatran dual therapy, as compared with 26.9% in patients receiving warfarin triple therapy. Similarly, the rate of major or clinically relevant non-major bleeding was significantly lower in patients receiving 150 milligram dabigatran dual therapy than in those receiving warfarin triple therapy. In the secondary endpoints, there was no significant difference in the rate of thromboembolic events or death between patients receiving 110 or 150 milligram dabigatran dual therapy and those receiving warfarin triple therapy. The authors conclude that in patients with atrial fibrillation after PCI, dual therapy dabigatran and a P2Y12 inhibitor significantly reduced the risk of bleeding as compared with warfarin triple therapy, with no increase in thrombotic complications. Full trial results are available at nejm.org.
Pros and cons. Strength frequency of cardiovascular risk during the stay in the care room coronary intensive. Some of the independent predictors for ARIA include higher degree of air failure, refusion time, cardiorespiratory arrest, tachycardia, hypotension, anterior localization infarction, previous air attacks, diabetes mellitus, habit of smoking, renal function, and biomarker like serum. Egg is very likely to level some degree of coronary air disease and blood pressure affects the coronary artery, making them more vulnerable to coronary air disease. The higher the blood pressure, the greater the risk of coronary air disease. Changing in the listas of Lea's passion.
Welcome to this educational program.
This module discusses the treatment of acute coronary syndrome, a collection of conditions resulting from coronary heart disease. There are other modules available that describe the causes, risk factors, and diagnosis of acute coronary syndrome in greater detail. This information is taken from a recent review of the medical literature and attempts to be as comprehensive as possible, and to decrease oxygen consumption by the heart in order to reduce chest pain, prevent further heart muscle damage, which helps prevent blood clots, thrombolytics, the standard blood clot busting drugs used to open the arteries, beta blockers, which reduce the oxygen demand of the heart, statins, or other lipid-lowering agents to lower cholesterol, including cholesterol and triglycerides. Since high blood cholesterol increases a person's risk of having a heart attack or stroke, the long-term use of statins reduces this risk and can increase the life expectancy of individuals with a history of heart disease. In addition, statins also appear to stabilize atherosclerotic plaques, making them less prone to rupturing and forming clots.
Después que pase el video, hablas y sigues hablando. ¿O qué le haces ahí?
Pravastatin, fluvastatin, atorvastatin.
Issue apply in Ecuador. Clinical decision-making tools continue to be based on a balanced assessment of therapeutic risks, cardioembolic coronary ischemic events, a bleedings. According to the Ecuadorian cardiologic magazine of medicine, non-anticoagulant soluble permitted with patient with a sorrow. Conclusion. Although within community will now autography with incorporation take result of the Augustus trial specific recommendation is declared tax only the field of policy in related to in public interest patient.
For atrial fibrillation patients, sometimes they will need to undergo PCI, and that mixture of the two diseases together has been a difficult problem to manage, in that we need anticoagulation for the atrial fibrillation, for PCI with a stent, dual antiplatelet therapy, and the triple therapy that results in both those together has a very high bleeding risk. And so we've been searching for how to reduce that, and the WOOS trial had suggested you could reduce aspirin and have less bleeding and still be okay on thrombotic events. It was a modest-sized trial, so we're all looking for more evidence. And then could that be done with a novel oral anticoagulant? And so that's what we tried to address in the REDUAL PCI study. So the trial looked at patients who all had atrial fibrillation and thus anticoagulation indication, had undergone a successful PCI, and on average they were randomized at 1.1 days later to different strategies, and 2 of the 3 were a dual antithrombotic strategy, and they used the 2 approved doses of dabigatran, the 110 and the 150 milligram twice a day dose, so that plus a P2Y12 inhibitor, and we allowed clopidogrel or ticagrelor actually, in there, and then the control arm was warfarin, clopidogrel, ticagrelor, and aspirin. Although the aspirin large part with WOOST, we already shortened the duration of the triple therapy because that's what was being. Hemorrhage was also lower. The balance that we look for is, well, if we take away aspirin, would that increase the risk of thrombotic events? And so we did pre-specify a non-inferiority comparison of both dual therapy groups together versus the triple therapy. And we found non-inferiority for an endpoint of death, MI, stroke, systemic embolism, or unplanned revascularization. Then looking a little bit lower down, that amongst the two doses, there were numerically lower rates of that endpoint for the 150 dose, and so really equal outcomes overall, and a slight 10, not significant, but slightly higher thrombotic events in the dual therapy 110 group. So without aspirin, the lower level of anticoagulation, some hints of higher, potentially higher risk of thrombotic events. And so out of this, I think it fits in beautifully to how we practice to try and individualize for patients, where if someone has big bleeding as a worry, that you could use a lower intensity anticoagulation in this dual strategy approach, or if not, to be able to use and have evidence for the higher dose of the 150 milligram dabigatran dual therapy approach. Well, it's fascinating that just 2 days before, guidelines incorporate the idea that we do in practice, but have a beautiful, simple figure of risk stratifying both bleeding risk and thrombotic triple therapy, or adopt the dual therapy approach. And we now add a lot of new evidence in support of that dual therapy approach. But this idea of risk stratification on bleeding and thrombotic risk is a very useful one. I think now we have a few new regimens to provide evidence of options to treat patients across the spectrum.